Hello and welcome to Reede Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Reede Scholars. Today, I am joined by Dr. Elna Nagasako, who is an internal medicine physician and also holds a PhD in quantum optics. She is also a Reede Scholar with an extensive experience in a large healthcare delivery system. And she currently resides in Hawaii. Welcome. How are you today?
I am well, Mary, and thanks. It's always a pleasure to talk with you.
You too. I'm just fascinated that you're in Hawaii, and I'm kind of sneaking a peek out the window over there, pretending. Well, how have you been? How has this past year found you? I know it's been a roller coaster of a year for most of us.
Yeah, I mean, I would say this year, as with many other people, it has been overwhelming in some respects. On one hand, I'm trying to balance, some of the downheartedness from a lot of the tragedies that have occurred, as well as with optimism around seeing a lot of topics that I think, those of us that have been working in health equity for a while kind of know we're there. They were always there. We were always hearing about them. We were always talking about them, but that maybe, having that wider audience, having more of that attention, hopefully will help continue to accelerate change. So, balancing downheartedness with hopefulness.
Definitely. I mean, we've learned a lot. I think we have a lot left to learn, but there's definitely an opportunity for innovation and optimism and changing things for the better. And so kind of with that, we of course spend all our time talking about health equity on this podcast, but we probably should take a step back and really think about what health equity means. And because now we're talking about it so much, is it changing our definition? So give us a little bit of some fundamentals, if you will, about health equity as you've known it and you've grown into it. And kind of your journey to health equity, and how do you see that definition changing in this last year and a half?
And so, wow, a lot of questions in there. So I'll start off just more maybe with, no, those are all excellent questions. So I think in my journey to health equity work, I would say, I smiled when we were talking, before this started about what was your PhD in, and it being in quantum optics and so forth. During that period of time, one of the things that started my journey was actually that I spent 3 years volunteering on a rape crisis service. And that was really my first immersion into really seeing how a lot of issues around trauma and around medical care, because we'd also go sit with people in the ED and just seeing the different ways maybe that people were treated by our healthcare system, and the different ways people would access services as we would link them to services. People with phones and insurance may be able to link better to services as opposed to those folks who are saying, I don't have a phone. So in terms of even trying to follow up with them, the difficulties that presented for them, or even with respect to housing, right? I would say at that point, I'd had the privilege of being able to take housing as like just something that people had, and to be safe in your own home, and then starting to volunteer in the course of the training, and then of course responding to these phone calls, seeing women, people of all genders, but mainly at that point in time, we were seeing a lot of women who maybe weren't able to be safe in their own neighborhood because they did not have the money or resources to move out of a neighborhood where they saw their, the assailant all the time. And so I think that really started my journey towards wanting to work to make those things better. And so I think I'd start off seeing the intersection of like poverty and different, discrimination and different kinds of things in that setting before then deciding to go to medical school and then to go into healthcare. In terms of the journey of health equity and the way I've seen some of the discussions evolve, I think some of the things that, obviously wide-ranging discussions, I've been very heartened to see the movement. I want to choose my words carefully. It is really important that we look at medical causes of differences in outcomes.
Right.
And, medical research and biomedical research, fantastic, really important. It saved the lives of folks in my family. I do not want to minimize that at all. And seeing the discussion more broadly go from kind of back, even before I started my medical journey around, hey, here are these, biological difference in outcomes, and we're going to ascribe that to race, to really broadening and continuing to broaden the discussion of saying, hey, so what is in our lane, right? What is in our lane as medical providers, as healthcare organizations, around what does it take to solve these differences? What does it take to reduce those disparities? And so a definition I like that I've seen, a lot of other places comes from the Robert Wood Johnson Foundation. And so that's really starting up just at the basic, it's got 3 parts, which I love, because it starts off just saying, what is it?
Right.
Well, it's health equity is when everyone has the fair and just opportunity to be as healthy as possible. But then they go this other layer and says, what is required? And the definition is very broad. It says, what's required if we want to, achieve health equity is to remove those obstacles. And they call out poverty, discrimination, and all the results of that. And I can't quote it exactly, but it's, talking about access to good jobs, we talked about safe environments, right? Good jobs, safe environments, quality education, quality housing, mitigating the powerlessness that comes with discrimination and poverty. And then we're talking about measurements, and metrics and so forth. So they finish by saying, with respect to measurement, what health equity means is that we're going to reduce and eliminate health disparities for groups that have been, adversely affected because of being, marginalized. So that to me is a definition that I like around health equity.
I do too. I think it's simple enough, but inclusive enough that gets to the heart of the issue, and anyone can read it and understand, what's going on. And kind of going off the last point, we're talking about measurement. So we talk a lot in across fields, right, about data and data collecting. It seems like, with this boom of technology, it's just more and more data everywhere. And we talk about data as it relates to health equity, and what type of data do we collect? Where do we collect that data? What do we do with the data when we collect it? How do we use it in a meaningful way? So there's lots of questions, and right now, because we're talking about health equity so broadly, in all honesty, and so many different organizations and corporations are coming up with chief equity officers and offices of health equity, and so, we have a lot of potential to get more data from different places, but tell us a little bit about how we should be collecting data, what we should be doing with the data once we collect it, and then how do we hold those people who are collecting that data accountable?
So all great questions. And so I think, as you're alluding to, right, there can be this feeling of, really, do we need more data? Don't we already have a ton of data? And, and even as a patient, right, sometimes when you go and you check in, and if they're adding more and more questions, just some survey you have to fill out thinking, I've talked to patients who are like, why am I answering more and more of these questions? And so I think one of the things that is very important is that data be tied to action. And I think that's true in general, right? As clinicians, we're taught, it's not like you're going to chase down every lab measurement. We're going to draw blood and do all this stuff. It's really, is that going to affect what you do? Exactly. And I think that lesson we learned as clinicians also applies in this sphere in a different way, meaning, are we collecting it just for the sake of saying we have it, or are we going to use it? And that, I think, links to accountability in the sense that, how is it being used? Because there can be times when we really want data from the standpoint of action. And we've seen that, with respect to race data availability, and that being able to separate, for instance, with respect to COVID, seeing the differential impact, the pandemic really laid bare for the whole country a lot of these issues that those of us working in health equity were already aware of, around the effects on the differential effects on different communities, in terms of race and in terms of, other vulnerability factors, right? But at the same time, that data sometimes is really hard to get at, or it's not publicly available, or it's not linked. This collected over here, and then this is collected over there, and they're not connected, or heaven forbid, right? Sometimes some kinds of these data are collected on like pieces of paper that then is in the file cabinet, right? And then there's this other humongous database, and how is that connected? Or even with respect to because here obviously equity can span many different dimensions, but here we're talking especially about racial equity, at this point. Sometimes one of the projects that I think a lot of different folks working in equity in healthcare organizations, perennially do is around, race data collection. How is it being collected? Is it collected in a standardized way? And then is it available? Even those kinds of really simple things then impact downstream when we need that data. We want to use that data and it's not available. And so one of my biases is really around that organizations especially really think about how am I using this data, and what will I need? What will the folks making these decisions need to have in front of them? And then letting that drive, the data collection. And also even what partnerships do we want to create? People have long been talking about, collective impact and so forth, but this larger concept of how do we collaborate? Are we using the same metrics as our allies in different organizations are that we want to partner with? Because if we're asking one patient to have multiple different kinds of questions all about the same thing, or we're looking at different outcomes, but in 12 different ways, again, we're leading to that multiplication of data, but it's not necessarily translating into action. And I think another area where we see maybe there's this broad sea of data, but there's also a lack is sometimes when I've seen really great statements from organizations about a commitment to equity, right? Sometimes those it's not always clear. What is that next level? Does the organization have metrics that they're following? How are, in all other spheres, right, of any organization, you're held accountable, right? At the end of the year, at the end of the quarter, whatever, for different metrics on performance, on quality, on so forth. Well, when it comes to the equity statement, when you peel that back, what are the metrics? Can people say? Because if people can't tell you what metrics they're following, it makes you question how carefully are the parties? Do they have sort of that specific, measurable, actionable, time limited, in a year, we are going to move this needle by this much, and I recognize the work is hard, and that a lot of these things, as we know, progress can take time. And if there's not a metric, I still do question the level of accountability that's there, so that, in a year from now, and 2 years from now, and 3 years from now, can we say this organization did this, and this, and it progressed? Or is it sort of like, now there's another unfortunate event or series of events, and then we feel like we're back, in 2020, and we're repeating it over and over, or before, yes, or before.
Well, I want to go back and underscore a couple of things that you said, and then I have a follow-up question to that. So one, we talk about health equity a lot, and I just kind of, for the audience, health equity, to your point, is a lot of different things. So we spend a lot of time here talking about racial and ethnic differences, but we also recognize that is not the limit of health equity, and we invite and encourage conversations around the health equity spectrum across the board. That's one.
Absolutely.
Two, even thinking about collecting data, so going back to racial and ethnic differences, though, and collecting data around that. I mean, I remember even when I was starting my first clinical job, which, I guess it was a decade ago right now, but they weren't collecting that data or language on initial intake, right? And so it's like, how do you go back and really assess quality, and you're missing these key pieces of data? And then even when we look at the data that we do have for even as recent as 5 or 10 years ago, you get Black, white, and other, right? Yeah. And so like, what is that telling you? So I was going to ask you just to speak a little bit about the nuances of, when we look at our different populations in this country, and then people who are coming from outside of this country into this country. I mean, that just adds to the layer
Absolutely.
measurement. So just, I mean, just briefly, not in a whole bunch of detail, but
Yeah.
how people should think about collecting race and ethnic data and being mindful of the many different categories under these big boxes.
So absolutely. So the first thing, because especially if folks haven't been working with these kinds of data, I think it can seem really overwhelming because it can be, right? It's a complex situation. And at the same time, there are well-established standards. So for instance, the OMB, the Office of Management and Budget, has set standards around here are the different race categories. So there are specific categories under race that all you can. So a couple different things. One, there are specific race categories and definitions,
Right.
first of all. And so that's the building block. Two, I think sometimes people, again, those that aren't familiar with the data tend to sort of be like, well, that must be the only categories that matter. No, what that means is just that this is what within the federal government, that the surveys have to be able to be combined down into, but that doesn't mean that's the only thing you can ask. Right. And so that's where, as you're alluding to, within, for example, Asian, or even more broadly, right? Sometimes it's lumped together, as you mentioned, in other. Right. That's pretty broad. And then, you get Asian, AAPI, so inclusion of Pacific Islanders. Again, what a broad group, right? In terms of very different, in terms of the different historical experiences and contexts tying into, present day experiences, right? And then within Asian, again, very, very broad definition. And there are, further, like when you look, for instance, at the census and the ways in which different questions are asked, there are different, again, just using Asian as an example, different groups, whether that's Chinese, Japanese, and so forth, it's kind of the largest groups by origin that are listed, and also a place to add, for people to add how they're identifying if it's not captured there. And I think already, right, I can imagine how it feels like people were getting in the weeds, right? You're now getting all into these details. The thing that I want to point out again is the tie to action. That when you look at the variation, using Asian as an example, like you say, okay, I want to really, help work on these disparities. And I know that they are connected to issues around poverty, discrimination, education, and so forth. So I want to do something. Well, if you just start off and you say, I'm going to grab, sort of the averages around Asian, and we say, well, the Asian poverty rate is, and these numbers, by the way, Pew Research has a great sort of set of policy briefs and graphs. So I want to say that's where I'm pulling these numbers from. But they, so the poverty rate on average is, I believe, 10%. But when you look at it, so some groups, that number is nearly half. Some groups, the poverty rate is even less than that. It's like 6% or 7%. You look at other groups, the poverty rate is over twice that. It's more like 1 in 4. And so if you are just mushing everybody together, you may not be directing your resources to the particular subgroup that needs them. So it's not just like a theoretical thing of how many boxes do I have in this form. It's really, do you have the information you need to target your resources, support your efforts in an effective way? Because otherwise, you might be not spending your resources optimally and effectively. And then, here, I'll stop there.
No, I mean, and I think, and that speaks to, one of those cartoons that we talk about equity all the time, where, you give everybody a box, right? Everybody doesn't need a box. Some people need 2 boxes. Some people don't need a box at all. So you really need to understand your population to know how to distribute your resources, or you're not really maximizing the help. So, but so going back to my follow-up question, which is tying into this. So we're talking about different organizations, talking about health equity, capturing data, kind of in this, we're not post-COVID yet, but this intra-COVID experience that we're having, and the concern about consistency, longevity, sustainability, accountability, all those things. So as a consumer, or as a potential employee, or even as a patient, and then you're looking at an organization and trying to understand if they are really committed to the health equity conversation, what questions would you pose to evaluate those organizations?
So I would ask three things. Obviously, we could, talk even more broadly. I could come up with more of them, but I think three things to start off. So one thing would be just, what are your goals and priorities? And just like we talked about, are they SMART goals? And by that, I mean, of course, that acronym of, specific, measurable, time-bound, resourced, and so forth. Another thing that I think is important and often missed in data discussions, because we think data is objective. The second one would be, who's included on those teams? And, there's issues around diversity, inclusion, both from just sort of that fundamental standpoint of, you've heard the phrase, nothing about me without me, and so forth, are the communities, who are you including in that discussion? And I think that's really important to ask and to recognize the expertise of, when we talk about marginalized, minoritized communities, a lot of times that expertise of those community organizations, those that have been working on these efforts in a long time, especially if they're smaller organizations or, again, talking about discrimination and so forth, people may not come to people's minds as, hey, those folks, those organizations should be at the table. And I think it's important, again, for the effectiveness of these programs and of the data collection, right? It's important to do things that are meaningful. Who's at the table talking about that? Who's talking at the table around that? So that's question two. Priorities, who's at the table? And then the last one, I think there's more and more attention to is really, there's the work, the organization that is outward facing and the metrics around that. And so just using healthcare organizations as an example, right? Their quality of care, their this and that. But, there's also attention to how are their employers? How are they treating their employees? What is the diversity inclusion? What is that experience, of employees at all different levels, from frontline to the C-suite of an organization? And that, I think, is an important question, and related question that to that would be, organizations are also purchasers. There's a group called the Healthcare Anchor Network that is really calling attention to this, right? They're employers and purchasers. In what way are their purchases of goods and services supporting, or alternatively not supporting, these local communities that traditionally have been disinvested in? What role is organization playing there? So I think those three questions around priorities, who's at the table, and looking internally, right? Is the organization really thinking about these other, employment, and procurement that maybe we don't always think about, especially in the healthcare space?
Definitely. I think those are all great. And I especially like the last one about really taking that inward look, and how you're treating because your employees are also part of your community and the community that you serve.
Absolutely.
So you're not taking care of them,
Absolutely.
then, I might question what, your other missions are and how you're executing those. So, so as we close, I don't want to keep you too long. I'd like to end with kind of thinking towards the future. So, as we talked about, this last year has been a bit of a roller coaster with lots of very sad moments, but also lots of moments for growth and innovation and reflection. So as you look forward to the next year, what are you hopeful for? Or what are you looking forward to, either personally or professionally? Like, just what's on the horizon?
I hope that, honestly, I just hope these discussions continue. I just hope that we're continuing to hold organizations accountable. I hope that, I made reference, to the whole thing, right, around what is in the lane, right? We've heard that phrase coming up, right, especially around gun violence and so forth, and healthcare providers in their role. I hope that people continue to be brave in lifting up these things that it's easy to criticize healthcare folks for speaking up and saying, well, that's not a part of, that has nothing to do with insulin, that has nothing to do with whatever. But I feel like the events have led people to really, there was the Reede Scholars, that panel really around, the recent panel really looking at policing and so forth, and recognizing those contributors. And I hope that bravery to speak out about all of these different issues that encompass health equity continues.
I love it. I think, to your point, we don't have a lane. I mean, our lane is taking care of people, and yes, we have to meet them where they are, and sometimes that is not in the office or in the hospital. So with that, thank you so much. Go out there and soak up a little sunshine for me. And I look forward to talking to you again. I always learn something for you. You are very insightful and you make me stretch. So I appreciate that. But thank you so much.
Such a pleasure to talk with you, Mary.
Thank you for listening to Reede Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.